Hello, can you see the screen?
Yes.
Okay, thank you. My name is Pete Vanderklish. I'm here representing the Spinogenix team today. I'd like to thank the organizers for inviting us to this excellent conference. And so today I will discuss the rationale for and what we think are exciting preclinical data supporting an entirely new therapeutic strategy in ALS, that being the pharmacological regeneration of glutamatergic synapses. And so Spinogenix was formed to address the synaptopathies, those conditions in which a loss of glutamatergic synapses in particular drives cognitive and motor decline. And as you can see from this donut chart on the right, the synaptopathies are etiologically diverse, very diverse. They span the neurodegenerative conditions that include dementias and motor diseases, but also include neuropsychiatric conditions, injury and aging, and neurodevelopmental disorders. If you look around this donut chart, you can see many of the major players that people are familiar with, but what's not widely appreciated is that ALS itself is a synaptopathy. And this is something I'll summarize the evidence for shortly. Unfortunately, many of the synaptopathies are devastating in their impact on motor and cognitive functions, and they're often progressive and fatal, as is the case with ALS. There are currently no therapies that will restore lost synapses in any of the synaptopathies. But what we know is that if you want to regain function, you will have to have a regenerative therapy that does exactly that. So Spinogenix was formed to transform the treatment of synaptopathies. And our unique solution to do this is to generate a platform of novel small molecules called the SPGs that have the remarkable property of restoring lost axospinous glutamatergic synaptic contacts in neurodegenerative conditions and other conditions. And this is schematized here in the middle. You see on the left an apical dendrite from the CA1 pyramidal cell in an animal not treated with an SPG. And on the right, you see one treated with an SPG. And of course, on the right, you see more of these dendritic spines. Of course, these are the postsynaptic elements of about 90% of all glutamatergic synapses in the brain. Now, SPGs act via a very novel mechanism of action targeting the synaptic cytoskeleton. And they also have a set of highly unique properties in terms of their activity, which are an excellent match for the unmet need presented by the synaptopathy. Now, to kind of convey these properties, the very unconventional pharmacology that SPGs have, we coined the acronym TAGS, which stands for Transient Activators of Glutamatergic Synaptogenesis. Now, these compounds, the SPGs, trigger the formation of new glutamatergic synapses, and as I mentioned. But what's remarkable is they only require transient exposure and low doses to do the job. These doses, they're effective in the low nanomolar range, in vitro and in vivo. We know they are rapid acting. They induce new spines within hours in vitro. And in vivo, we see rescue or improvement in behavioral symptoms within days to weeks. Now, based on the data that we have so far, our working model is that SPGs induce a self-perpetuating and self-limiting process. That is, you don't blow the doors off the system by making too many synapses. That carries forward on its own to generate physiologically relevant numbers and shapes of dendritic spine synapses. And what this offers is a first-in-class regenerative approach to treating the synaptopathy. So as I mentioned, ALS is a synaptopathy, and there's very good evidence that dendritic spine synapse loss occurs early in the disease and is a nodal event across many causes of the disease. And we know this from post-mortem studies of familial and spontaneous ALS cases in which synapse loss is found in motor cortex and in lower motor neurons. You also see spine synapse loss in the prefrontal cortex, and this correlates in degree with cognitive deficits in those people who have that symptom. And it's not due to cortical atrophy, indicating it's a primary effect on synapses. And you also see synaptic protein reduction in these studies. Now, in mouse models, there's a lot of data supporting these observations. For instance, in many models in motor cortex, you see loss of dendritic spine synapses on motor neurons. You also see that happening in motor subcircuits as well as cognitive centers prior to symptom onset. This precedes overt dendritic atrophy, and in many cases, as well as overt cell loss. And it occurs in limbic centers as well. In the spinal cord, there's evidence that the most susceptible neurons, the fast fatigable ones, show synapse loss before symptom onset. And other ones that are more resistant show synapse loss about the time of symptom onset. And then a paper just came out recently that showed that cytoplasmic mislocalization of TDP-43 is alone sufficient to induce large decreases in dendritic spine synapses in the brain. And among those studies that have looked, it appears that the synapses that are lost in ALS, the excitatory ones, predominantly include those that have mushroom-shaped mature spines. It's the postsynaptic element. This will become relevant in a minute. And so, as I mentioned, I think I mentioned, this has not been sort of widely embraced by the field, that synapse loss is something we should really be looking at as a nodal event of pathogenesis of the disease. So I compiled this chart. I won't go into any of this data in detail, but what this is a summary of all the in vivo evidence for synapse loss in ALS across postmortem studies and animal models. And suffice it to say that there is robust replication of the basic observation that synapse loss occurs at pre-symptomatic stages of the disease very early across many genotypes and at symptomatic stages as well, and that it's progressive. And we think this evidence combined with other evidence provides a very strong rationale to consider synaptic regeneration as a new therapeutic strategy in ALS. Now, to this end, we are repurposing, or positioning, I should say, our clinical lead candidate, SPG-302 in ALS. In essence, we're leveraging this TAGS technology to reverse synapse loss in ALS to slow or reverse the progression of motor and cognitive symptoms. Now, we think this strategy can be used alone as a monotherapy, but also in combination with other emerging therapeutics. Excuse me. Now, SPG-302 is a new SPG with excellent drug-like properties. It's patent protected. It has extensive proof of concept behind it in animal models. It's highly selective at the target. It's orally bioavailable in a simple formulation. It has excellent blood-brain barrier penetrance, and as far as we can tell, it has a shockingly wide therapeutic window. We've interacted with the FDA. They've granted us orphan status, and they are in agreement with our plans to go forward with an adaptive phase 1/2 trial in ALS subjects, which we anticipate starting in about 12 months. So a good example of the effects of SPGs, in particular our lead compound on dendritic spine regeneration and rescue of phenotypes, comes from a study we recently published in collaboration with the Lafrilla Lab at UC Irvine. Now this study used, it was SBIR funded, this study used the triple transgenic mouse model of Alzheimer's disease, and at an age when they already lost 40% of the glutamatergic synapses in hippocampus. So this equates to about mid-stage Alzheimer's disease. Now what they did was they took these mice and they treated them for 4 weeks, once daily IP with 3 or 30 mg per kg of SPG-302. And they found that that treatment was enough at the end of a 4-week period to return spine density levels to near normal, statistically indistinguishable from wild types, as well as to rescue the levels of synaptic markers and rescue hippocampal dependent memory, spatial memory, and contextual fear memory. And you can see the effects on dendritic spines in the figure on the right. We return numbers of total spines to normal levels. And if you break it down by spine shape, you can see that the mushroom-shaped spines were returned to normal, as well as the stubby spines. And again, these are the ones that seem to be preferentially lost in ALS and in some other synaptopathies. Now, importantly, we've gotten some new exciting data in an ALS model in collaboration with Justin Uchida at USC. In this, he's used a rapidly progressing, very severe model of ALS called the 12 mouse model.
COVID-19_vaccine for information.
Mouse model. And so this overexpresses human TDP-43, and the homozygotes have a very severe phenotype. So they die within about 22 to 25 days after birth in a very stereotypical fashion. And they begin having motor symptoms around day 14. So they started dosing at day 14 after symptom onset with our compound 302 at 15 mg per kg once daily. And what they found was that SPG-302 dramatically improved motor phenotypes in this system. And so these are the group data across 3 domains of motor function: gait impairment, kyphosis, and tremor. And in the graphs on the bottom, all the, if each higher scores on the y-axis equate to worse impairment, The black lines are transgenic mice treated with vehicle. The red lines are transgenic mice treated with SPG 302. And you can see that 302 delayed the progression, slowed the progression of gait impairment. It delayed the onset of kyphosis, the hunchback posturing, and was adopting to become weak. And at the end of the treatment, there was phenotypic separation in terms of a Parkinsonian tremor. So nothing shows it data like a video or an effect like a video. And we'll play this here. What you see are two mice, both transgenic. The one with the short tail has been given the vehicle. The one with the long tail has been given our drug, SPG 302. Now, clearly the short-tailed mice is having, a lot of problems. It's hard to move around. His legs are splayed, indicating weakness. You can see kyphosis and a tremor. Meanwhile, the drug-treated mouse, the one with the long tail, is moving around more or less like a normal mouse, at least close to it, running circles around the other mouse. And so this is evidence of clear benefit of the treatment in this transgenic mouse model. Now, even more importantly, and actually much to our surprise, a pleasant surprise, SPG 302 prolonged the survival of mice in this very severe, very aggressive model system. And so you can look at the Kaplan-Meier curve here in the middle of this slide, and you can see the median survival was increased by 35% through administration of SPG 302. And only knockout of ataxin 2 gives comparable results in this model. Now, when you consider the survival and the motor effects of SPG 302 together, they're quite remarkable considering the following. One, this is a very aggressive model, as I mentioned. Two, dosing was initiated after symptom onset. This was not a prophylactic treatment, and we nevertheless got an effect. It was once a day exposure to a very short acting compound. Again, these are molecules that get in and get out and do their job. And with such an avalanche of pathology in this model, you might think that synapse loss is occurring extremely rapidly, and maybe more frequent dosing would have been better. And then finally, we don't know of any intrinsic neuroprotective activity of SPG 302, indicating that the survival effect is probably due to the regeneration of glutamatergic synapses with primary neural activity. Now, another important symptom in ALS, of course, is respiratory failure. And we did not test this in the TAR44 mouse model. However, we do have insights into the potential utility of 302 in respiratory symptoms from studies on spinal cord injury. And so in spinal cord injury, it often involves the cervical spinal cord, which can impinge on axons that innervate phrenic motor neurons that control the diaphragm. And this can result in impaired breathing. Some patients require mechanical ventilation. Now, this has some mechanistic parallels with ALS that we think are relevant. And we, in collaboration with a team at the Mayo Clinic, Drs. Matt Fogarty and Gary Seek, tested SPG 302 in a rat model called the C2 hemisection model of spinal cord injury. And basically what this is if you look at the diagram on the right, which is the chain of command, if you will, and the neural control of breathing, what they do is they sever axons on one side of the spinal cord that are descending from premotor neurons to phrenic motor neurons that innervate the diaphragm, leading to complete abrogation of diaphragmatic activity on that side of the spinal cord, as quantified by diaphragmatic EMG, electrophysiological reporting. So it's a very defined lesion, a very severe paradigm, and a very quantitative outcome measure. Now, in this system, about 20% of rats will spontaneously recover a very modest amount of diaphragmatic activity. And this involves synaptogenesis, which is the reason we thought SPGs might be effective in this model. So they tested SPG 302 at 15 mg/kg starting on the day of the lesion and going forward. And what they found was that SPG 302 profoundly increased the rate of recovery from this lesion, which again is a very severe defined lesion, a very quantitative outcome paradigm. So if I can draw your attention to the graph in the lower left, you can see the percentage of rats that show EMG recovery after lesion at days 7 and 14. And whereas the control vehicle treated rats in open circles achieved a recovery rate of 17%. At day 14, those treated with our compound recovered at a rate of 86%. So this is it's a whopping increase. And in addition to that, the magnitude of diaphragmatic activity that was recovered, as assessed again electrophysiologically by EMG, was greatly increased. And you can see that in the graph next to in the middle. We got about on average a 54% recovery of pre-lesion EMG activity. Now, some examples of traces are shown in the middle. I'll just draw your attention to the green rectangle in the middle. And here you see the EMG on the lesion side and on the non-lesion side in SPG 302 treated animals and vehicle treated animals. And you can see abrogation of the EMG in both at the day of the lesion. But if you move over to the right traces in the right rectangle, you can see that in the drug treated animals, you got a recovery of the diaphragmatic EMG activity, but not in the vehicle control. So this is a very dramatic rescue effect in a model of spinal cord injury relative to the breathing phenotype. And so this may inform on the potential utility of 302 and ALS. And it's fair to ask the question, can SPG 302 increase glutamatergic drive of phrenic motor neurons that control the diaphragm, or perhaps even premotor neurons upstream or pattern generator neurons upstream as well? And would this improve respiratory force and rhythm? This is something we're going to test explicitly in an SOD1 rat model of ALS soon. Now, we're excited by these data, and we think they provide a compelling rationale to go forward. One thing I would like to also mention is how differentiated our approach is relative to everything else out there in the pipeline right now. I've tried to summarize all the different strategies that are coming out. I've probably butchered it, but this is my feeble attempt. If you go across the top, and I've organized it by modality, genetic, biologic, small molecules, or cell-based, versus what you're trying to do ultimately, which is to either slow progression or maybe regenerate some aspect of neural circuitry. You recognize a lot of these. In the top left would be ASOs, and the bottom right would be perhaps mesenchymal stem cells to increase trophic factor support. We, against this backdrop, no matter how you arrange everything, stand out as the only therapy that involves small molecules to regenerate glutamatergic synaptic connections. And we think this approach will be relevant to all phases of the disease, from pre-symptomatic to symptomatic, and to regenerate lost function, to regenerated synapses. And we think this would be an excellent complement to any of the other approaches, because even if they are effective at slowing or stopping the progression of the disease, there's no guarantee with any of them that you will get the synapses that you have lost back. And then finally, some of you may have the question, is this disease modifying? Is it the case that regenerating synapses is simply giving you back some function because you've reestablished circuitry and you have absolutely zero effect on underlying mechanisms of pathogenesis? Or is it the case that biologically, by restoring synapses, something that are lost very early in the disease process, one of the first dominoes to fall actually, are having some kind of back propagating effect on underlying molecular pathogenesis? And I would at least raise the possibility that that is the case. And here are a couple of reasons why. First, we know that glutamatergic drive actually early on in SOD1 mice is protective. If you stimulate AMPA receptors, you extend lifespan and reduce pathology. If you inhibit them, you have the reverse effect. We know that spine density in many circuits is correlated with vulnerability to the extent that motor neurons that die early have large and early deficits in spine synapses, whereas those that die later or are resistant either retain their spine synapses longer or have more spine synapses. We know that spine loss could trigger other features of ALS, such as the reemergence of hyperactivity and hyperexcitability or change in release probability. And then finally, the known genetic lesions that cause ALS, many of them cause impairments in the expression of proteins or in the activity of processes that are important for the generation, maturation, and stability of dendritic spine synapses. So it's reasonable to ask the question, might normalizing spine density actually engage protective mechanisms early in the disease process or block some aspects of pathogenesis? We don't know. But at least now, for the first time, we have a pharmacological tool and a potential therapy to test these questions explicitly, SPG 302. So I'd like to thank our team, and most especially Justin Cheater and Rita Sattler at USC. Somehow I forgot to put Matt Fogarty and Dave Seek on this list as well. We thank them. And if you have any questions, do that.
Thank you. That's very stimulating and represents a new way of thinking about therapeutic intervention, as you so nicely outlined. We do have some questions in chat. One is, probably many of us are thinking this is from Dr. Krishnan. Any ideas on the mechanism of action? Can you say a bit more about how you get the glutamatergic synaptic regrowth?
Yeah, well, what I can say in the context of this meeting is that it's highly unique. It's cytoskeletally targeted. And what we think we are doing is we are coaxing a very early process in the sequelae of molecular events that lead to spinogenesis. So a good example of what, of how a very brief trigger can induce the formation of new dendritic spine synapses in vivo is what happens with LTP-inducing stimulation in young animals. And so there you have an inductive trigger that lasts on the order of maybe 1 to 2 seconds, leading to new synapse formation that occurs hours later. Now, one of the first things that LTP-inducing stimulation does to increase the efficacy of the synapse and make new contacts in that context is to reorganize the actin-based cytoskeleton. And that's where we think we're acting. We're coaxing the reorganization in a sort of hit and run mechanism of action. And that then carries forward on its own to complete formation of new spine.
Thank you. There's also a question that concerns potential hyperexcitability that could be induced if there are, for example, too many glutamatergic synapses. Do you see any evidence of seizure activity induced after therapy, or indeed any other form of excitotoxicity?
Well, it's a good question, but we have seen zero evidence of ever producing supernumerary spines. We always seem to induce physiologically relevant levels of them. We have never seen any seizure activity, and we've dosed many, many animals across many different paradigms, and in some cases, very high doses, many orders of magnitude over what we would use clinically. And then finally, I think, with regard to ALS in particular, there might be this paradox actually involved where, naturally you might think that, this hyperexcitability in the ALS brain is due to things like changes in intrinsic excitability of neurons, but also in the probability of glutamate release. The thing is, a lot of those changes are reactive. One of the first things that neurons do to compensate for loss of synaptic input is to increase excitatory, or to increase the probability of glutamate release, and also to sort of change the intrinsic excitability. Now, if you restore normal densities of dendritic spines, you may restore that balance. And you may also change the sort of EI coupling within dendrites in a way that's natural. And we don't expect overexcitation or exacerbation of excitotoxicity at all.
Thank you. 2 other questions, and we'll move on. Is this positive effect irreversible? And if not, how long does it last, and what are the implications for dosing?
Very, very good question. Unfortunately, I don't have a very constrained answer for you. I would say that, the fact that we are inducing mushroom-shaped dendritic spine contacts, which are by far the most stable glutamatergic synapses in the mammalian brain, would argue that once you get them there, there might be some durability to the rescue effect. Yeah. That said, every pathology, every synaptopathy presents its own, hurdles. We don't know the rates of synapse loss in these cases. And what we know pragmatically, and we haven't explicitly tested how long, after treatment cessation would it persist. What we do know pragmatically is that once a day treatment is doing very good, and at the same time is doing no harm. So that's our intent right now, is to do once daily treatment.
Thank you. Let me ask also, I'm presuming that this is, I think you made it clear it's a selective glutamatergic effect. So presumably there's no effect on the neuromuscular junction peripherally?
Yeah, that's another good question.
Other than what you would see if you restore the motor neuron, but no direct effect on synaptic peripheral structures.
We're not aware of any effect in the neuromuscular junction at this point.
I mean, and presumably the EMGs you showed at the diaphragm were showing electrical activity, not denervation, by the same token.
Yeah.
Okay. All right. Last question. Was any histology performed on the TAR4 mice after treatment? Was there restoration of or prevention of loss of synaptic structures centrally?
All I can say is that is in progress in Justin Machida's lab at USC, and we're chomping at the bit to know that as well.
Thank you. Thank you very much. Very stimulating.